calling some psychotherapists, and most of them just have the answer, please, I'm full, I cannot take any more patients. So that's the situation we have, and I think that's pretty much the same in the Western countries. So when we now come to the cost situation, and that is really important for, especially for the side of the health insurance companies, we see that around 15% of the days of incapacity for work are due to mental illness. And in average is 33 days. For depression, it's 43 days. That's the longest number. So if you have back pain or some other conditions, it will be shorter. It's the highest number, 43 for depression, if you have an incapacity for work. And this is about 56 billion euros every year in the year 2020 health expenditure. So maybe that's time to do something against it. So if we summarize that, we have these long waiting times, we have these supply bottlenecks, and then there comes another thing, reservations and stigmatization of the illness itself, so of mental illnesses, but also of the treatment as psychotherapy or medication is large in Germany. So we have around nearly 70% of the people who do not get any treatment who have a diagnosis of depression. They are untreated. And we see for psychotherapy that remission rates are about 50%. It's not, so inadequate. So the high costs that come along with this, maybe we have something we can do about this. And so we had to look into the evidence of exercise, and I just brought the meta-analysis I published with my team last year, where we just had really rigorous only exercise, strength and aerobic exercise, very strict control groups, and we found a large SMD here of nearly 1 - 1, so a large effect here, included 41 studies. And we just look at the low risk of bias assessments with the ROB2, we still see a moderate effect here. Then you might be aware of the SING meta-analysis, which is different. It's a meta-analysis of meta-analysis, and they included everything. Kind of meta-analysis who had a look at depressive symptoms. So even if there were people with cancer or some other conditions, they were included. And what they saw in the 72 meta-analysis is that physical activity, so they looked at physical activity, reduces mild to moderate symptoms of depression, anxiety, and mental disorders. All populations, and the reduction in symptom was comparable to or slightly larger than for psychotherapy and pharmacotherapy. And then you might be aware of that one because it's from Mike here from the group around Mike and Chris. And I had the honor to review that one. So I really went into that one. And hopefully they still like me. And what they found is, they had to take out the dancing because that was the best effect, but it was only 2 studies, so not to overemphasize that. But walking, jogging, endurance, strength training, yoga, tai chi, qigong were all effective and well tolerated, especially strength training and yoga.
Dancing has music too.
Yeah, but the only thing as a reviewer, I just said because it was only 2 studies, but it has a large effect, so they need some more studies. The next time they can put it in the abstract as well, if they like. And it seems that larger effects are seen for high intensity in the group setting and with clear structure and specification. And again, here comparable to those of psycho and pharmacotherapy. We have to say here, only studies are here included that compared exercise to psychotherapy or medication, so not too many studies. So if you want to have a closer look in how psychotherapy works, you should look at the meta-analysis of Kuipers, who did a lot of research in that area. So the agreement, and these are the most recent meta-analysis on that, is that exercise can be a further evidence-based treatment option for the large amount of untreated individuals. But we have to say that still there is some research needed on long-term effects. We do not really know something about that, about severe depression. This is mainly in the other areas, and the comparison with first-line treatments is also necessary. There's not too much around this. So I brought you the meta-analysis we did to just have a closer look at intensity here, or at the type of exercise or the group exercise, and you can see that we cannot see so much here. So we do not really know what type of intensity is the best. Still, there's some like moderate intensity, some analyzers say. But if we really have a closer look, we know exercise is a good treatment option, but we do not exactly know about the conditions what should be applied. So we know a few things. I will show you that a bit later. Just here in the guidelines. So these are the German guidelines for unique mild depression. And they do not include the meta-analysis you just saw, because they were updated in 2022, and the meta-analysis are from 2023, 2024. But even here you see a strong recommendation level. And what they say is patients with a depressive disorder and no contraindication to physical exertion should be motivated to engage in sporting activities. That's not coming from me, ideally within a group. And the modified version is here, patients with a depressive disorder should be motivated to participate in a structured and supervised exercise program and should be supported in its implementation. So again, that's not coming from me, but that's what the guidelines say. But in Germany, it's not an available treatment option in healthcare. So if you're going to a physician, he does not really know where to send you if you want to have some exercise treatment. And I think that's the same here. So that's why we did this STEP-DE study, which is a multi-center cluster randomized trial, and we compared exercise therapy to psychotherapy. So it's a non-inferiority trial here in the healthcare sector, and it was funded by the German Gemeinsamer Bundesausschuss. It's called, it's an innovation fund with 2 million. I was the main PI in that one. And the objective here was to see if exercise therapy offered by psychologically trained exercise professionals in healthcare in comparison to standard psychotherapy is after 16 weeks and after 6 months, if that does work, and also apart from the depression severity on some other outcomes like the health-related quality of life. And then the non-inferiority approach, if after 16 weeks and 6 months, it is non-inferior to psychotherapy. And then one really important thing is the costs, if it's less costly than psychotherapy. So that was the main hypothesis. And the inclusion diagnoses were 10. So there were more than just the depression itself. So every kind of diagnosis that usually or might come along with depressive symptoms, we included here. And as you can see here, like the blue ones are the psychotherapists. So that was a special thing. Like we had a psychotherapist at the beginning with an initial consultation just to check if the diagnosis fits or if there are other conditions. We might have to exclude them because they take medication and they're not allowed to exercise or some other mental disorders. And then there was a sports entrance test, one-on-one with a sports therapist that was trained. And then they got into the exercise therapy group for 4 months for 32 units maximum, 1 to 2 times per week for 16 weeks. And then afterwards, a final interview with the sport therapist again. And you can imagine that there was something going on with the training they got, especially here in the final interview to see how they could implement exercise, physical activity, movement in their daily life or in their weekly life. And then there was a follow-up consultation mainly with the psychotherapist to see if further treatment was necessary. So if they should start the psychotherapy afterwards because they needed further treatment. And yeah, mainly it was endurance training, strength training, because of course we have the the broadest evidence here, and then also some mindfulness-based exercise with increasing intensity. So the first 7 sessions, it was just to create kind of a safe environment. People could feel safe there, and then could proceed with higher intensity. And the exercise therapy was in small groups, 4 to 6 mainly, maximum of 12. And they were instructed by sports therapists, which means that they needed to have a degree, like a bachelor degree in sports science or physiotherapy or anything equivalent to that. And then they underwent a specific training, and with the psychotherapists, same. They needed to be psychological psychotherapists, and 95% of them were mainly cognitive behavioral therapists, and we cluster randomized them. So one of them was with them in the exercise therapy group, and the other one did the treatment, the psychotherapy treatment. So they were randomized in these. So just briefly, what did we teach them? So we had 2 weekends of teaching, twice 2 days. Mainly about the professional approach in crisis and emergency management, because generally exercise therapists do not know that much about that in their studies. It was about communication and goal setting. It was a big one where we introduced, or where we used also already basic psychological needs and the promoting of motivation. And then, of course, a deeper understanding of mental illnesses, especially depression here. So just briefly, the flowchart, we can go back to that maybe in the discussion as well. As you can see, there's kind of some dropout as expected. And these are the outcomes. So we use the BDI as a primary outcome, and then MD as a secondary outcome. I will also show you today the health-related quality of life outcomes, and also I think I've got some workability outcomes here. We also measured basic needs, sports motivation, mindfulness, self-efficacy, IPPEC, to know a bit more about that. It was a 2-on-1 randomization, and the IMITT sample were then finally 344 patients. And as you can see here highlighted, we had to adjust for age, which we did with the covariate, and in the analysis, which, as you can see here, the sport therapy group were a bit older, and but we had no differences in depression severity or depressive symptoms or quality of life or any other measures on the baseline in these values here. So here come the results, and as you can see, no differences between the groups. Both significantly reduced the symptoms over the 4-month course. Also, over the 10-month course, which means 6 months later, with a 6-month follow-up. I mean, we can go into the discussion here more intensively after the talk. And the same for the MD. If you're not familiar with BDI, it's it's a questionnaire you fill out, and the MD, we trained assessors who were blinded to the groups setting, and they assessed it via telephone. And as you can see here, the exercise group slightly better, but there's no significant difference here for both measurement points. The same outcome here for the health-related quality of life. There is a significant increase over time, no difference between the two groups. And here's the work and social adjustment scale. And also you can see here same results. And I could go on with this with a few other measurements, but that's all the same. One really interesting thing we found is because of the non-inferiority analysis, you need to have a great power, which we didn't have. I think it was nearly 70% of the power, so a bit underpowered. And as you can see here for the BDI, in the 95% confidence interval, we are slightly out of the 95% confidence interval by 0.06, which means we cannot say that exercise therapy, and that's the follow-up. So for the intervention time, there's no we can say it's non-inferior, but for the 6-month follow-up, and then you can see for the T5 for the 12-month follow-up, it's out of the range already. Interestingly, for the HEMD, we are within the a priori defined non-inferiority limit. But as I said, we defined BDI as the primary outcome. So for the 6-month follow-up, we cannot say this. But to bring more light into this, where this effect might come from, just have a look at the lower costs for the experimental group, for the exercise therapy group. So we can see after 4 months, this is the rate of the starting or the proceeding of the psychotherapy. What that means is we have 22% of the exercise therapy group who, after the 4 months of the exercise therapy, started a psychotherapy. 77% of the psychotherapy group proceeded the psychotherapy, which means, of course, there is a much larger dosage in that group of treatment than in the exercise therapy group. And if we go back to the non-inferiority analysis, this might be the effect that's coming from that, because to put it the other way around, 80%, nearly 80% of the people attending the exercise therapy group did not need any further treatment after 4 months, whereas 77% of the people in the psychotherapy group, which is expected because psychotherapy generally lasts longer than 4 months, proceed with psychotherapy. And interestingly, that's also the main cost that arise from that. As you can see, it's around 300 euros less costly the exercise therapy group compared to the psychotherapy group, which is a significant effect. And then it's around 1,000 euros the exercise therapy group less costly than the psychotherapy. Here a closer look, just some analysis ran on the long course. As you can see here, the psychotherapy group declines more in the follow-ups than the exercise therapy group. But as I just said, that might come from the higher dosage of intervention. So to summarize that, the results here from the STEP exercise therapy show that it's effective in treating patients with various psychiatric diagnoses. After 4 months, it proves to be as effective as psychotherapy at a lower cost. And at the 6 and 12-month follow-up, STEP is still effective, but not non-inferior to psychotherapy. And then we have all these nice results, which we handed in, and we got an evaluation report, and everybody was very excited about these results, and everybody wanted to proceed with that study. And then the question is, how can we proceed with it? Who is responsible for that? So the health insurance companies say, yeah, we pay for it, but we cannot run it. The university is not the right place. They say, we're doing the research, but we do not implement it and run it. So out of this, I founded this Center for Emotional Health Germany, because there was nobody around doing that. And with a lot of help from the University of Potsdam and the state and the European Union, so we founded that. And what we're doing now is that we offer the qualification courses, that we're working together with the health insurance companies, contracting them, doing quality assurance, so to say, and building a network and an infrastructure for health professionals, because I just had a talk to 70 psychotherapists a few weeks ago who were very interested in this, to implement some more movement in their practice, but also to send some people over to some other treatments, additional treatment or just standalone treatment. and the same applies for physicians. So that's where we're working at the moment. We have around 60 professionals who are trained, mainly in Berlin, but as you can see from the map here, it's starting to be more in other areas of Germany. We just contracted a community of around 40, a bit more than 40 health insurance companies, mainly small ones, who want to just bring that to their patients because they, of course, they see what it's, how it can help on the one side, but on the other side, they can see where they can save some money as well. What is missing is the implementation research around it and the inclusion of patients' feedback. So we're working on this at the moment. Here is just the modules we set up, and you can do this course now online, which I don't like that much, but this means we can bring it everywhere in Germany. And I think it's like my team set that up very, very nicely. So it's a really nice learner experience to do that online course. As you can see here, the basic psychology needs is one module, but it's integrated in, for example, the communication and the goal setting and other areas as well. And it's not only limited to the STEP-D study, because if a health insurance company is not covering the costs yet, and we're like, people are applying of our webpage, they say, okay, I need some treatment, I would like to do some exercise for my mental conditions. We train them in bringing them in any kind of movement program. So they need to be aware of also like protective factors of exercise or the other things that you can see here. And the other thing that comes along, and I think you're very well aware of that, we have now exercise professionals who are just doing that for their own, because they can see, okay, I will be less stressed out, I will be more motivated, I know where my responsibility lies. I think in our system, we are very much educated, like if you're going to a physician, you just hand over the responsibility for your health. And this is some really big thing that we do in this course, that we, train them about their role and where they can create a supportive environment for their patients, but where the responsibility for their own health lies within the patient. So thank you a lot for listening, and looking forward.
I was looking at this research, which is ancient history. The big issue was that people that did this, the exercise that stayed with it did as well as the people that did the psychotherapy. But in general, the dropout rate for the exercise people was a lot higher because it took a lot more effort than taking a pill. And I'd be curious about your comments on that.
Yeah, what we saw in our study, there's not a difference in the dropout rates between psychotherapy and exercise therapy. But I totally agree. Like we're kind of trained in this to take the pill, maybe, which is easier to just take the pill and make a habit out of taking a pill than exercising. So one of the main things in the course here is how does behavioral change work? So at the beginning, they have this first session with where they set the goals and the responsibility. And we were really astonished about how many people did not have the goal to get rid of the depression. So there were different goals. They want to lose weight or a lot of different things. And I think that's one of the main things. Like as an exercise professional, you get a depressed patient, you think he wants to get rid of the depression. But bringing that responsibility about how can I support you, helping you, working on your goals. We just first have to explore your goals. And if we do that at the end again, and they're making like all these small little efforts and nice experiences within the exercise therapy. Because a lot of people reported that they had bad experience already in physical education. And they were like, the main question was arising is like, I've never been good at sports. Can I really attend the program? So the main big thing was to bring them in the entrance testing and to take these fears because they felt safe in that environment. So that was the main thing. And then they stayed. And then at the end, it was just about, okay, what did you like most about the exercise you did here? Was it the strength training, the endurance? Like we did something like you had some back pain, so we're working on your back pain with the strength training, of course. And or was it the mindfulness-based stuff? What could you integrate in your daily life easily? You could stay here, you could go to a fitness studio, you could just walk the steps. Does that answer the question?
Yeah, to an extent. I mean, the issue is that you didn't actually have drug only. And so but the fact that you had relatively low dropout, what was the dropout rate?
No, the dropout was, I think, 30% to the second follow-up, like 6 months, and then nearly 50% to the 12-month follow-up.
But how much of that was people dropping out of answering your questions or dropping out?
Yeah, right. So we don't like
that was the issue.
We cannot be sure about that. So
Yeah.
we try to get every measurement point. But there were also some people who like dropped out of the exercise therapy and went to the psychotherapy. I think there were 2 cases of that.
What did you do? What did you do in the analysis with the dropouts?
So we used for the main analysis, we used the MITT sample, which means like we list the last observation carried forward. We were just very rigorous about like we can discuss about that if this should be done if you like have a T0 and then you just forward that because that's conservative in a way. So that's what we did in these analyses. But we're thinking about further analysis as you just saw with the I think with these analyses, so we're thinking about having more like mixed models and then including more the dropout in a different way. Or we had some problems also with the measurement points. So some of these people, not too many, we just got them way out of the measurement point when it should have had happened. So within the 2-week circle, it was like 3, 6, 7, 8, 10 weeks later. So we're adjusting for that just to make sure that nobody who did the exercise therapy proceeding with the psychotherapy is not confounded by that, having already some psychotherapy treatment when we measured the afterwards. But as I know the numbers now, there are 2 people confounded by that. So every we ran a lot of analyses. The results are very stable, very, very stable. Even if we are like the per protocol analysis, on even if we are more rigorous on that, but it goes on cost of the power.
So for the missing people, you just took what they had the last wave and carried that over. You didn't do a FIML or.
Not yet. So that's just for the MITT, and for the main results we handed in and they are published online already.
Is FIML an appropriate way to deal with dropout? I'm not. That's a question. I just don't know.
I can answer that because I looked at this just the other day. You end up with slightly more biased results than intention to treat, and so the conservative approach is what you've done, which is to carry it forward, because that assumes that the worst case scenario is the one that you're reliant on, rather than one where you get to benefit from. One of the problems with FIML is that even if you obviously don't include the intervention as a variable when you're doing the FIML, because you don't want to know which group that they were in. But the models tend to be very good at detecting things that tell you that they were in the intervention anyway, like the trend that was going on. So the most conservative approach is what we've done.
Well, it's clear that that's the most conservative, but did you say that it's the most accurate?
In the simulation study I read the other day, there's not a lot of difference in terms of results, but they thought that the results would be more biased.
And I understand that. I was just curious as to what that is, because I could see it being either, I could see the FIML being more accurate. And of course, your carryover strategy was more conservative.
What I was also thinking about, and I had to look into this, and it's not widely used, is last observation carried backward. So you just have a look at the nearest measurement point to where it should have been, because we got some measurements sometimes way out of where it should have been, and that's not a lot of people, but there could be an approach. So at the moment, we're doing some work on on these time slots to group these people if they because we had the COVID pandemic as well. So we did when that started, we said, okay, let's just do the measurement right here now after, I don't know, 10 weeks. And then we had a T1A and a T1B proceeding. So all these adjustments.
You could also do just a continuous time model where you just took time as a continuous variable.
Yeah.
And you didn't worry about.
That's what we did here, I think. Yeah.
Results. I'm wondering in CBT, as you mentioned that the most approaches was CBT, yes?
Yeah.
That's good. In CBT, we do have behavioral activation to help, clients to be more active. And doing exercise is a part of this behavioral activation. And how did you control this one?
Not at all. Because it's like in health services research, we just said, okay, let's just do the treatment as usual. Whatever they want to do. That's why we pairwise randomized the psychotherapists in like center-wise, I think it was gender-wise, and then on what they offered as treatment. Like I think it was one pair of psychodynamic psychotherapy, and all the other 34 pairs were CBT.
And I'm wondering, did you record the brain EEG,
No.
to figure out what is the
No.
difference between?
Like on the mechanisms, we did a study before on that speed study, and we sent 150 people. There was just coming out as a new paper on, I think,
3 days.
neural activation. So we put them in fMRI with some blood samples on BDNF and IGF-1. I think there's just one paper published also on IGF-1 or on LabClean. I mix it up. So, but yeah, that's about the mechanisms. But to be honest, the mechanism research is just a start, in my opinion. Like there's a lot out there with BDNF and also some on, like we put them in the scanner to do some emotion regulation tasks and working memory tasks and so on, so that we're just about to publish more on that. But we don't see so much on that, like especially on the blood parameters, like BDNF.
But
Sometimes it's contrary, and I think the literature went just sometimes in one way and everybody was following, and we get some contraries.
I'm talking about that one that record your brain and give you a picture which part is green, which part is red.
Do that. No. So this was 350 patients, and it was just like, okay, even the IPPE, I'm not happy with the IPPE, but it's the most widely used physical activity instrument. So we will have a look at that. So we can see if, for example, in the psychotherapy group, they started to do more movement because of that approach that is used in CBT. Yeah, and we just said, yeah, do whatever you want to do. If you go jogging with them, if that's the normal thing you would do in a CBT session, which normally is not, but there is some activation coming along with that, and going like climbing up a high tower. There's also some physical activity to face their fears or whatever they do. We did not control for that.
You said that you couldn't differentiate between the different types of activity. But really what you were saying was, another way of saying that is that it didn't make much difference what kind of activity, physical activity they had, that all of them were more or less equivalent. And that seems like a much more positive spin.
Yeah, totally. Yeah. So it is more about like the approach we took, and that's why I was not so interested in we do some, like that was what we did in the first study. We had high intensity endurance training, low intensity endurance training, and a waiting list control group. No differences. So, and I know that especially on anxiety or there, like with high intensity, there are some good results, but then you find some other things. And the meta-analysis, just what I can see from the meta-analysis at the moment is supervise it, do it in a group, and then look at what people, like if, for example, endurance training, high intensity, if you have people that never exercised before, we had so many people that were so happy to not die being on a treadmill and then making that experience. You cannot bring them on an 80% heart rate maximum on the treadmill. So that's why we train the exercise professionals, just to like create this environment, as we know from basic needs theory, to see, okay, and then they help each other in the group. So what we saw, like from the reports of the exercise professionals, like, and also we recorded some reports, we did some qualitative reports you can also find online. How was the experience of the people? And they all started like this. It was so hard to even go to the exercise session. I had to really make the approach to like put my rucksack at the door, because if not, I would not go. And then after 1, 2, 3 sessions, I just made the experience. I was just talking to other people, not about my depression, but about the experience they made within the exercise. And they reported after 6, 8 weeks, I feel so different. And I love to come here. This is really my area. That's for me. And it's not my kids, not my husband, not my work. So, and further question could be, has it to be exercise then, or could it be just a social environment? I think the exercise itself holds some really valuable, like you go there in some jogging and you're in a group, you're all the same. Anyway, you look the same. And then there comes some effect from the physical activity itself. We know that. But I think, and hopefully I'm allowed to say this as a sports therapist, I think we overemphasize the physical aspect of exercise and underestimate the social and the psychological aspect of it. And nobody measures that so far. Or those ones who measure, we have really poor measurements on that. So we can measure the blood and whatever. But the psychosocial, there's so many different things that play a role that is hard to measure.
With your online stuff, is that individual? There's no groups, there's no therapists
With the online, what do
for
you
your online version?
No, so we have like the online version is the training for the professionals.
Oh, okay.
And they're doing the training.
So this is an online version.
What we had to implement, what forced us was the pandemic to have some online exercise therapy. And then afterwards, we opened that up. So the group is very small, so we cannot do a subgroup analysis on that. But what we can see within that, it works the same way. But it's a group exercise therapy online as well.
Oh, I see.
But the approach is not that individual than it can be. And I really like the approach to have people in a setting somewhere.
Yeah.
But for the health insurance companies, as they're not trained exercise professionals everywhere at the moment, we have now people coming from somewhere in the world, I could just say, but somewhere out of Germany and doing that online because it helps them. But we do not have data on that. It's just my feeling that I, as an exercise therapist, would say, okay.
So your online, for the online, it was actually in groups,
Yeah.
But it was virtual groups?
It was also small groups the same. Like they had a big screen, like the exercise professional had a big screen,
Yeah.
so to see everybody on the screen. And then we simplified the exercise therapy. So they didn't need any, like they just needed a mat, something to sit on, and a towel. That's it. And then we did everything with that.
And were the participants a group or were they
Yes.
Individual? But all on the screen.
No, they saw each other on the screen.
Okay, so it was individual, but a virtual group.
Yeah, and the interaction is quite limited
Yeah.
if you see each other on the screen.
Yeah.
So everybody was busy doing his exercises more or less. But the exercise professional was also trained in this to try to make some socializing within that. There was a really small group, and the health insurance companies in the contracts we have with them, they really push that so that we are able to make an offer to everybody at that point, because we do not yet have that network of a few thousand therapists, exercise therapists in Germany at the moment.
Or anywhere else.
Yeah, that's what we are. Hopefully, we're heading to. So, at the University of Potsdam now, this course is integrated. We have another few universities who want to integrate the psychological training in the bachelor degrees already as what they can choose out of. And we just started this semester, and we have the first. I think we have 7 students who applied for this, and 6 who are doing that course now. Yeah.
When you say sport, you really just mean exercise?
Yeah.
It's not really a sport. Or
Yeah.
sport like a team and all.
Or even physical activity,
Yeah.
which is less onerous than exercise.
So I think I'm just in Germany. It's sports. It's the same. Sport and exercise is the same. So what I'm talking about exercise therapy. So
What would be a moderate? Is that on the mat or walking or what's
So-
moderate?
we use the board scale just for what they felt like, and then we also used the heart rate. And
What would be the activity?
so for the endurance training, we put them on a treadmill, so they had 20 minutes just on that, and you can really like with the heart rate, and you can monitor that.
Are you walking or running?
And they were sitting on a bike. Yeah, mainly. Sometimes when the weather was good, they went out to some. I don't know if you know Nordic walking, like with the sticks. Nobody does it here. But it's very popular in Germany because you're like moving your arms and your legs, and you can like do some good exercise out of it.
We have a few machines that stimulate it.
I was talking the other day at the before university about it, and we were like, no, that's just in the spring. Some Europeans come over and you see them walking around, but it's no training, doing body walking. So there was that approach, and then we had the strength training, which was mainly with body weight, but there were also some machines, and there was a plan they could do depending on what further could like. A lot of them had back pain or some joint pain, like knee pain or hip pain or whatever. So that was an approach that was more individual, but could also be like sometimes some training just in the group on a mat. And then the last 20 minutes, they were very open, and we just wanted to do the exercise professionals something they really felt good with. So if they were a breathing instructor or yoga teacher or Pilates or whatever, there was one of the exercise professionals. She's like 55 or so, and she was also did some training in other areas. So she put on some candles, and she had a men group, mainly men, 50 and above. We were all, oh God. They loved it. And I wanted to proceed with her in other courses then, because they loved the relaxation, and they did some dream traveling, whatsoever. And I think the setting of first having the aerobic exercise, being able to just do this stupid aerobic exercise, maybe talking to someone, just focusing on my breath, on my heart rate, on how do I feel. Then doing the strength training, especially for men, then doing some powerful stuff, and then then they are prepared to do some relaxation. If you do that at the beginning, they're like, it's nearly not, maybe not possible.
What did the psychotherapist or your psychotherapist friend say? The people in the other condition. When you show non-inferiority, maybe we already know this.
So mainly
Do they push back? Do they say?
yeah, there's mainly a positive resonance on this because they see that these 70% of like the thing is people, especially older men, they would not have opened up to psychotherapy right at the beginning. So we had a few ones who who dropped out because they said, I wanted to do the exercise therapy, I don't do the psychotherapy. So because they were randomized. But after these 4 months, having like seeing that the psychotherapist is just a human being, and you can talk with them. And after the 4 months, if there was further treatment needed for this 20 something percent, they started with the treatment, and they were open for the treatment then. So it's also like the stigmatization is also going down from psychotherapy. And yeah, just at the beginning, and that's what you can see also in the numbers here. Because the psychotherapist, like you can see that here, the exercise therapy group starts a bit lower in the BDI already. And at the beginning, we had some problems with the psychotherapist who was like, no, I think it's like the depressive symptoms are too strong. Just exercise. So we had to train them really, like, and they had to see, like, when they had the first patients, they made the experience because they also had telephone calls all 4 weeks, I think. Yeah, 2 or 3 telephone calls, just to make sure is everything fine. And mainly the people were talking about the weather or like, yeah, exercise is really nice. So the psychotherapist also made the positive experience. Oh, exercise actually could work, maybe nearly as good as psychotherapy. So that's why I think why we see a bit of a difference, which is not significant. But at the beginning.
A quick question here. So with the severity of the symptoms, I was just wondering that in depression and maybe across other psychological disorders as well, sometimes you have psychosomatic symptoms.
Yeah.
So did any of your participants have those symptoms, or just generally, do you think that if you have psychosomatic symptoms and let's say because of depression, you are throwing up and you really need some medication for that purpose, so is exercise going to have a positive impact in that case as well? Or
we didn't look at that, but we also had the BSI, we had some pain, some sleep, looking at like these things that are more related to psychosomatic. But one, I think, important thing I didn't tell you yet is where did we get the patients from? So we got them from the health insurance companies. So they just screen the diagnoses from a physician, like if there was coming in a diagnosis from a physician, they just called the patient. So they nearly contacted with a letter or with a call around 4,000 patients, and at the end, not even 400 did the exercise therapy. But if you think about your health insurance companies calling you, so we trained all the health insurance company managers. What would you do if they call you and tell you, we have here a new study, would you like to, because you have depression. So most of the people reject it because it's in Germany, nobody from your health insurance company normally calls you. And if they just want to ask you if you're happy with the health insurance company. So we got really people who are not generally walking around, I would say, and looking for studies, because that's in most studies, you get always these people who are more open to, go to participate in the study. So we got really people who were hesitant about and not even thinking about the therapy. So that I think the sample is quite, in that way, quite unbiased in a way. But they had to have this diagnosis, so as a main diagnosis. And then that's why we did the screening with the psychotherapist. The psychotherapist was trained to check if there was other conditions around, like if there were, I don't know, other psychiatric conditions, so that we could include them or not. But for example, they had back pain, of course we could include them. And the approach we use, like with the exercise and the psychologically trained exercise professionals, of course, that combines two things, and they working, for example, on their pain levels, which helps maybe in the other way as well. And with the psychotherapy, you are just having the talking therapy, so to say.
Excuse me, did you say that you had 4,000 people contacted by the health insurance company and only 400?
Yeah.
Wow,
But mainly they got a letter. That was it.
still,
But it's
and
we get
was this free to people?
well,
So it was free being in the study?
Yeah.
So, so the 4,000 people got something from their health insurance company saying, here's a new interesting study, it's absolutely free, and only 10%.
Yeah.
That's
because
interesting.
people are very suspicious when it is about mental health. Because most people, when they were reporting about their problems, they were talking about work. And nobody wants to have a mental condition related to the work in any way. Like anybody knows in the work field. So
You didn't do this, but it would be fascinating. Are the exercise and psychotherapy, are they complementary? If you had an intervention that had a combined exercise, and would it be better than either of them alone, or would it be more or less the same? That would be fascinating to know.
yeah, if the effect combines, like if it
What's your,
I don't think so. But I think
you don't think that it would be any better?
I don't think that it's like, I know from other studies that it is not like, it not doubles the effect, not at all.
No, obviously not, but is it different from either one alone? Never mind, I mean, you don't have to speculate.
Yeah.
Yeah.
I think that the way to go is, and that's what the question was really good, what do the psychotherapists think about? Like there are psychotherapists who just want to park the people for 4 months, because that's the waiting time, or 4 to 6 months. Because if they're not treated, severity, I mean, they can vanish, but in a lot of cases it doesn't, and it gets worse. So they see it, and we see that for the 20%, that was perfect to get psychotherapy afterwards. And this will be interesting to have a look at that subgroup. What is the effect compared to those ones who only got the exercise therapy?
Yeah.
So we will have a look at that. We can kind of a bit of answer that effect of 4 months of exercise therapy, and then like the preceding initial study of psychotherapy.
It's not the same question, but it's a fascinating one.
But to go back to that question, there are also like, there's a lot of money in that system. So to answer that question, coming back to you, is not all of the people being involved in that mental health area are happy with it. And the thing is, what we see again is like, we know I would say since 5 or 10 years, the evidence is strong enough to implement XR. When we just have a look at on which evidence level psychotherapy was implemented into health services, I don't know how many decades ago. I think we should have exercise therapy as a treatment. But there is no lobby, there's no, it's not exercise physiologists or physiotherapists in Germany, I think that's worldwide, are not organized like physicians or psychotherapists. And that's the main issue, main problem. So we will see. We have one psychotherapist in our group, and he's not so happy about it. He's bringing, I would say that's the main reason why we did not publish this yet, because he's bringing up another thing, and the timestamps and this and that. So there are things, of course, that's good to look at, and maybe it will save us some reviews. But already 1.5 years ago, to just give you a dimension, I was in contact, sending the manuscript to the editor-in-chief of the Lancet, and he really wanted to have it, which doesn't mean anything, but mainly it means it would undergo a revision process. So we're really deeply looking into the data before we do anything else.
Now, how about
Let's say-
introducing a health psychology module into psychotherapy training programs?
That's funny because when I was doing the talk with the psychotherapist, the main question was about, could we become sports or exercise psychotherapists? Could you just set up kind of an educational, are we really thinking about that? Because this could be like a good approach to say, okay,
I thought that's what your network was.
Yeah.
When you showed the map, I thought that's what it was.
So what do you think we are past time, by the way, so if anybody needs to leave, don't feel rude if you need to leave. But what do you think the optimal implementation framework looks like? You know, like your person goes to their GP, the GP says, I think you have depression. What happens next so that that person ends up being prescribed exercise? Like, do you think the GP should be changing to refer to sports therapists who are trained in this, or should they be referred to psychotherapists who are trained in sport, or is it some combination of the two? Like,
so the first thing is, and that's what we are already offering, is free courses for physicians to get to know the benefits and the limits of exercise therapy for mental health. I think that's because most, like if you have a physician in Germany, it's like, okay, he gives you a physiotherapy, you can go to a physiotherapist, you can do that once or twice for your pain or whatever you have. And then he has to look at the costs. And then he's thinking about, okay, what else? Maybe some surgery with the back pain or whatever. So with chronic diseases, the physician really quickly comes to a point where he doesn't know what to do and where to send the people in Germany. Because surgery is maybe not the adequate treatment. And then the question is what's in there. So they could send them to exercise, which is on a really low level. So you just have a coach who's doing that, and that's on a really low level. So what I would do is like really educate the physicians, get them some points for the licenses and so on. That's what we do at the moment, and do that online so they just know. And then just what we did is put up a system where they just can refer to, they can just send the people. And then the people at the moment, what we do is like, we have trained people in just I'm missing the word. They're just talking with the people and figuring out what will be the best to do, because they're trained, they know about the STEP program, but they know also about other mental health programs, and they know about exercise itself. So they can then decide, because the psychologically trained exercise professional is not only doing the STEP program, that's just a little small amount. So the main reason why people are doing that doing the training courses now, because they will apply that to all the courses they do. And I think that's the approach to go, because they then know, they're trained, and they know, okay, is exercise the adequate treatment? Or do they need to see a psychotherapist, a psychiatrist, or whatsoever? So that's in the training course already. And I think on the other side, we should do that with the psychotherapist. We have just a little training course. It's also for free, just that they know, okay, what are the benefits? It's the same with the physicians. And we should implement more about like an extra training so they could do integrate movement in psychotherapy, which is not that easy because the system is not built like that. And then you have like all the professionals know from each other, and then they just can like send people to the right treatment. So the main thing is when we train the people, it's like everybody that that comes to you, you offer something. It doesn't matter what, but maybe you're just a little training center. You just have some yoga courses and some weight loss courses or whatever. Just have a look. The most important thing is the psychologically trained professional. Because as we see, it does not so much matter what kind of exercise we do.
You started off with the first study was a meta-analysis of a -1 effect size. Is that with a control compared to control group or compared to before after? Because -1's huge.
Very, very good question. I was so deeply into meta-analysis. That's a pre-post.
Yes, pre-post.
Yeah, I know, and the Cochrane also, they're just doing post meta-analysis.
Did you say they were random controlled trial?
Where all randomized controlled trials
So you could have looked at it with the control group as well.
Yeah, so we use the pre and the post assessments and the SDs of both groups.
Okay, so the difference,
Yes,
okay, then,
but that's the different.
It is a person control group.
Yeah.
That's a real -1. I mean, it's huge.
Yes.
I mean,
And
I
that
would
was
say
really
it doesn't
like
have
we
-1
threw
effect.
every, like you might know the Kuhn Cochrane meta-analysis. There's a lot of bias in that one. That's from 2013. And we threw a lot of studies out of that meta-analysis because it was confounded with psychotherapy, with medication, with like the control conditions and even the exercise conditions. So we were very rigorous. I was like every single study. One problem about the pre-post analysis is the dropout. So if the dropout is too high, you cannot rely that much on the pre, like the effect that you get can be biased. Yeah.
for the pre-post, you use the standard deviation, not the standard errors.
Yeah.
Because I remember a lot in the early days of meta-analysis, a lot of people, the pre-post use the standard error of the difference rather than the standard deviation, the difference in it, these hugely inflated effect sizes.
Yeah, no, we adjusted for that because some of the studies did not, like we had to do a lot of recalculations to get the right, because it's weird, especially the pre-concert era, what they report and especially what they do not report. So that's why I brought like the results with the, I think you can see that here. One more back. Like the low risk of bias assessment with 12, it's only 12 studies, but it's the more than 10 studies which Cochrane states as you can do that. We even here see an effect size of -0.67. That's the effect size that psychotherapy finds mainly. And that's the real, and we can talk about the confidence interval here, which is quite large, not large, but it's, yeah.
Didn't you include, sorry, just a quick one, along with psychotherapy and exercise, like, didn't you include medication
No.
on purpose? Like, was there any specific rationale for not including medication as a potential treatment option and then looking at its efficacy as compared to?
Because we looked at mild to moderate depression, generally that's not treated with
Okay,
with drugs.
that makes sense, yeah.
But of course, we have a group when we look at the BDIs, severe depression. Like
What about
30.
suicide? Did you exclude those ones
Uh,
with suicide types?
That's why we like the main reason why we had the psychotherapy, therapists kind of accompanying the exercise therapy was because of this, because no gaps between the controlling of if there is an increase in depression severity. But we had no severe adverse events. Yeah. So it's sore muscles and some back pain, but no, thank God. But I think that mainly comes from there was no severe depression we were looking So there's another study that was done by a colleague. They just published that a few months ago in Lancet Psychiatry. They looked at 400 people also in healthcare services, and they had severe depression included. But the thing is, nearly 70% of the people getting the exercise also got psychotherapy or medication. So 2/3 of them, it's like the confounding, and they got good results. And this is the study where you can see that there is an additional effect of exercise. So they did not do the subgroup analysis, but that will be the analysis where you can see in this, like 50% of them got psychotherapy, and then 70%, so there was some medication and psychotherapy, but these 50% will be interesting because they got both interventions.
But it wasn't random assignment.
Sorry?
It wasn't random assignment.
It was a randomized.
Random assignment between the therapy and there was a random assignment for 2 people who got exercise only as opposed to people who got exercise plus.
Yeah, so the randomization was treatment as usual or exercise and treatment as usual. So that was the assignment. And as we can see, 1/3 of these people did not get any treatment, but the bias is quite high if you like. And they published that in Lancet Psychiatry. But the methods were very good down. But I think, what do we find out about this? Like, most people do not even get no treatment at all. So what do we get out of this? 70% got treatment. So very nicely done study, but as we see, we had some problems with our study with the power then, but I think that's the way to go, to just have exercise or just have a single treatment and not multimodal treatments. It's too expensive and not available.
I think we might call it there, but I encourage you to keep chatting with Andreas if you have further interest in this. So another round of applause and thank you for.
It stimulated a lot of interesting conversation.
Obviously, a lot of us need therapy.
You need it.
Yeah, I'm happy to. I will stay a bit longer than before we go to table tennis.
No. The table tennis is after our team meeting. So
Okay.
if we're going to play table tennis,
What time is it?
15.
I think I will be here.
Okay.
We can have some more discussion in the time.
Good if you can. I understand if you can.
Thank you, Andreas.
Wanting to do.
Just before I go on,
Thank you very much.
were there any issues that came up?